All right, get ready. We're about to take a deep dive today into nervous system surgery coding.
Ooh, sounds intense.
It is, especially if you're prepping for that medical coding exam.
Yeah, those exams can be tough.
And that's where our trusty guide comes in, the Absolute Medical Coding Institute's Medical Coding Guidelines Manual.
Ah, the MCG manual, a coder's best friend.
Exactly. You can find the link to it in the description below, by the way.
Always good to have that handy.
Absolutely. So we're talking about procedures on the brain, the spine, even those tiny eye muscles.
It's mind-blowing when you think about it, the precision involved.
Yeah, and the stakes are incredibly high.
Oh, absolutely.
So let's jump right in. We'll start with skull-based surgery, which already sounds like something out of a sci-fi movie.
You're telling me accessing the brain through the base of the skull.
Where do we even begin with coding that?
Well, the first thing you need to consider is the surgical approach.
Okay, so like how they get to the brain.
Exactly. Think of the skull base like a three-door garage. You've got the anterior, the middle, and the posterior.
I'm picturing it.
And choosing the right door depends on where the surgeon accesses the skull base.
So that's the first piece of the coding puzzle.
It is. But there's another layer to consider.
Okay, what's that?
The duramater.
Now remind me, that's the...
It's that protective membrane that surrounds the brain and spinal cord.
Right, like an extra layer of security.
Exactly. And whether or not the dura is involved really impacts your cutting selection.
Got it. So surgical approach plus dura involvement equals our code.
You got it.
Now, what if a surgeon needs to perform multiple procedures during a skull-based surgery?
Ah, good question. If the same surgeon is doing multiple procedures, think of it like a volume discount.
Okay, I like where this is going.
We use modifier 51 to indicate those additional procedures.
So they get properly compensated for all their work.
Exactly.
That volume discount analogy is helpful.
Glad you like it. Now, what if we have different surgeons involved?
Oh, good point. How does that change things?
Well, in that case, each surgeon would report their specific procedures separately.
So no modifier 51.
Nope, and no modifier 62 either.
So it's like each surgeon gets their own invoice.
Precisely.
Makes sense.
Yeah.
Now, what about those more intricate repairs during surgery?
Like what?
Like if they need to do grafting or use a flap of skin and muscle to rebuild the area?
Those are complex reconstructions. Think of it this way. Grafting is like patching a wall.
Interesting.
Cranioplasty is like replacing a section of the roof.
Okay.
And a myocutaneous flap is like borrowing bricks from your neighbor.
I love these analogies. So are these repairs coded separately?
Absolutely. Just like a contractor would charge separately for each type of repair.
Wow. So skull-based surgery coding is like putting together a puzzle with all these different pieces.
Exactly. And remember, always match the approach code with the code for the main procedure.
Makes sense. So like making sure the right door leads to the right room in that skull-based garage analogy?
Precisely.
All right, I think I'm getting the hang of this.
I think you are. You're natural.
Well, let's see how I do with the spine. Let's move down, so to speak, and talk about laminotomies and laminectomies.
Oh, those are good ones.
So what's the difference between those two again?
It's all about the level of access.
Okay.
A laminotomy is like creating a window in the lamina, that bony arch of your vertebra.
So just a peek.
Yeah, exactly. While a laminectomy is more like removing a whole section of the wall.
To access the spinal cord.
You got it.
So what are the main things that determine which code we use for these procedures?
Well, just like with real estate, location is key. You need to know which part of the spine we're talking about.
Cervical, thoracic, or lumbar?
Right. And of course, the number of vertebral levels involved is important too.
So how many floors the surgeon worked on, using our building analogy?
Exactly. Now, there's one scenario that can be a little tricky.
Oh, what's that?
It's when you have a decompression procedure performed at the same level as a posterior lumbar interbody fusion.
Okay, so two procedures at the same level.
Right, but they're technically separate procedures, even though they're often done together.
So we need to code them separately.
You got it. You'd use code 63052 or 63053 to capture that decompression aspect.
Along with the code for the fusion itself.
Exactly.
Right.
Like ordering a combo meal, but listing each item separately on the receipt.
I love that.
Glad it helps. Now, another thing to watch out for is whether the procedure is percutaneous.
Percutaneous, meaning...
Going through the skin with minimal invasion.
Like those tiny incisions for laparoscopic surgery?
You got it. And if it's percutaneous, you'll use specific codes like 62287-0274T or 0275T.
Okay, so we need to pay attention to the technique used as well.
Absolutely. Every detail matters in this coding world.
I'm starting to see that. It's like learning a whole new language.
It is. And the more you practice, the more fluent you'll become.
Okay, we've tackled the skull and the spine. Now for something even more intricate.
Ooh, what's next?
Eye muscle surgery coding. Ready to zoom in?
Let's do it. Those are some fascinating procedures.
They are. And I imagine the coding is just as complex.
Oh, absolutely. You're dealing with these tiny muscles that control incredibly precise eye movements.
Yeah, I can only imagine. So what are the first things a coder needs to consider with these eye muscle surgery codes?
The first key is differentiating between horizontal and vertical eye muscles.
Like navigating a grid.
Exactly. You need to know which direction the muscle controls to pick the right code.
Got it. So horizontal versus vertical is the first step.
It is.
What if the surgery involves both eyes or different types of muscle corrections in the same eye?
Excellent questions. If we're talking different eyes or different procedures on the same eye, we use Modifier 59.
Modifier 59, okay.
It's all about specifying the distinct services provided.
So each procedure gets its own line on the invoice.
You got it. Just like itemizing separate repairs on your card.
Right, you wouldn't want to lump a tire change and an oil change together.
Exactly.
Anything else we need to keep in mind with eye muscle surgery coding?
Documentation, documentation, documentation. Make sure any additional procedures are clearly documented.
Like add-ons to the main service.
Exactly. The clearer the documentation, the smoother the coding process.
Makes sense. So far, we've covered the skull, the spine, and now those intricate eye muscles.
We've been busy.
We have. And thanks to your expert guidance, I'm already feeling more confident.
Oh, I'm glad to hear that. But we're just getting started.
Oh, there's more.
There's always more to explore in the world of nervous system surgery coding.
All right, bring it on. I'm ready for the next challenge.
All right, let's do it.
Okay, so what other fascinating areas are we going to explore in the nervous system?
Well, we've spent a lot of time inside the skull and the spine, but now we're venturing out.
Out.
Yeah,
All right.
to the periphery. We're going to talk about extracranial nerves,
Okay,
peripheral nerves, and the autonomic nervous system.
so all those nerves branching out from the brain and spinal cord.
Exactly. Reaching every corner of the body.
It's like we're mapping out this vast nervous system network, one code at a time.
That's a great way to think about it.
So what do we need to know about coding these extracranial and peripheral nerve procedures?
Well, a lot of it comes down to, you guessed it,
Location.
location. You always need to specify whether we're dealing with a cervical, thoracic, or lumbar nerve.
And I'm guessing we also need to know if the procedure was unilateral or bilateral.
Bingo. Unilateral meaning one side of the body,
Right.
bilateral meaning both sides.
So if a surgeon repairs a nerve in both legs, for instance,
You'd use Modifier 50.
there it is again.
It makes sense, right? We're capturing the work done on both sides.
Absolutely. Makes perfect sense. Anything else that stands out in this section of the MCG?
Well, something that often trips up new coders is image guidance.
Oh, yeah, that's becoming more common in these procedures, isn't it?
It is. And for codes 64479 through 64484, image guidance is actually bundled,
Bundled.
meaning it's included in the code itself.
Okay, so it's like a built-in GPS for the surgeon.
Exactly.
So what if image guidance isn't bundled into the code?
Always double-check the documentation to see if any additional diagnostic imaging was performed.
Because that might be coded separately.
Exactly.
Okay, I'm seeing a pattern here. You got to capture all those details.
You got it. Now, let's talk about those tricky paravertebral spinal nerves and branches.
Yeah, the ones that run alongside the vertebrae.
Right. Now, here's a coding nuance for you. You code by the injection level, not the injection itself.
Okay, so we're coding for the specific nerve level being targeted.
Exactly, not the number of injections.
So even if they inject medication at 3 different spots along the same nerve level, it's still just one code.
You're catching on quick.
And if it's done on both sides, we'd use Modifier 50 again, right?
Absolutely. You're on a roll. Now, here's another interesting tidbit. Sometimes ultrasound guidance is used.
Oh, like we see in so many other areas now.
Yep, and if it is, it's reported separately using codes 0213T through 0218T.
Okay, so ultrasound guidance might be an add-on code.
Exactly.
Anything else that could trip us up with these paravertebral nerves?
Well, sometimes image guidance might be omitted.
Omitted. Why would they do that?
Well, various reasons. Maybe the patient has allergies or the equipment isn't available.
Oh, right.
In those cases, you would use codes 20552 or 20553.
Okay, good to know.
And here's another coding tip to keep in mind. Facet joint injections are coded by the joint, not the nerves.
Okay, that's a subtle but important distinction.
It is. One nerve block level actually involves 2 nerves.
Wow, so we really need to understand the anatomy behind these codes.
Absolutely. It makes all the difference.
All right, we've covered the nerves themselves. Now, what about those procedures involving destruction by neurolytic agent?
Ah, yes, those are often used to treat chronic pain.
Now, how does that work exactly?
Well, it involves using agents to destroy nerves, muscles, or glands for therapeutic purposes.
So interrupting those pain signals.
Exactly.
How do we go about coding these procedures?
First, you need to determine if it was done for destruction or for therapy.
Okay.
And then you identify the specific nerves, muscles, or glands being targeted.
And if it's bilateral, modifier 50 comes into play again.
You know it.
Now, what about those diagnostic injections they sometimes do to pinpoint the location for treatment?
Those are bundled into the main procedure code.
Bundled again.
Yep. No need to code them separately.
So it's all part of the package deal.
Exactly.
Any other coding pearls of wisdom for this category?
When coding for destruction of muscles or facet joints, make sure you're counting the treated structures correctly.
Okay, so multiple injections in the same facet joint would still count as just one joint.
Precisely. One joint, one code.
Got it. Now, I have to ask about a term that always throws me off. Chemodenervation.
It sounds intimidating, but it's actually pretty simple.
Okay, break it down for me.
Chemodenervation is basically injecting chemicals to temporarily paralyze muscles.
So like hitting the pause button on those overactive muscles.
Exactly. It's often used to treat things like spasticity or muscle spasms.
So how do we code for chemodenervation?
The key thing here is how many extremities were treated.
Extremities, okay.
And you only code once per extremity. The maximum you can combine is 4 extremities.
So even if they treat multiple muscles in one extremity, it's just one code.
Exactly, because it's
Yeah.
all within that same extremity.
What if they treat trunk muscles?
Oh, good question. For trunk muscles, you'd use codes 64646 or 64647.
Okay, so different codes for the trunk.
And if they treat additional muscles beyond what's included in the base code, there are add-on codes to capture that.
Like building a custom Lego creation. You start with the base and add those special pieces.
I love that analogy.
Makes it much less intimidating.
Right.
So for chemoinnervation, we're considering extremities, the trunk, and any additional muscles.
You got it. And just like with neurolytic agent destruction, if the documentation mentions administration of the agent...
We'd report that separately.
Exactly.
And any diagnostic injections are bundled.
You're on fire. You've got this.
I think all these analogies are really helping. It's making the coding logic click into place.
I'm glad to hear it. But remember, clear documentation is key.
Oh, absolutely. Makes our job so much easier.
It does.
Okay, we've covered a lot of ground in this section. What's next on our nervous system coding adventure?
Let's talk about those high-tech osseointegrated implants.
Ooh, sounds futuristic.
It is, especially when it comes to hearing restoration. Ready to dive in?
Absolutely, let's do it. Okay, I'm ready for this. Osseo-integrated implants, break it down for me.
All right, so osseointegration is all about how the implant actually fuses with the bone.
It becomes part of the bone.
Pretty much creates the super strong connection.
Wow, that's incredible. Like the implant putting down roots.
Exactly. And this is especially important for things like bone-anchored hearing aids.
Oh, right. I've heard of those.
So these hearing aids rely on that osseointegrated implant to transmit sound vibrations.
Directly to the inner ear.
You got it. Bypassing any problems in the outer or middle ear.
So it's like creating a whole new pathway for sound.
Exactly. Allowing people with certain types of hearing loss to hear again.
That's pretty amazing. So how do we code for these osseo-integrated implants?
Well, just like before, the surgical approach is key.
So how'd they get the implant in place?
Right. Was it percutaneous, through the skin,
Uh-huh.
or transcutaneous, involving a skin flap?
Okay, so different approaches.
Different levels of complexity, and that's reflected in the codes.
Makes sense. What other details do we need to pay attention to?
Well, were any additional middle ear repairs performed during the same surgery?
Oh, right, like fixing other things while they're in there.
Exactly. And those would be coded separately.
Each procedure gets its own line on the invoice.
Precisely.
Okay, so anything else to watch out for with these implants?
Documentation is key.
Of course.
It needs to specify the type of implant used, all the surgical details.
So coders can paint a clear picture of what happened.
Exactly. Accurate coding starts with accurate documentation.
Couldn't agree more.
Right.
Well, this deep dive has been eye-opening.
Glad to hear it.
We've covered so much skull base, spine, eye muscles, and now these amazing implants.
That's a lot to take in.
It is. But you've explained everything so clearly, I feel like I'm starting to grasp the complexity of this coding world.
Well, that's the goal, to make it feel less intimidating and more understandable.
And you've definitely succeeded.
Shucks. Well, don't forget, the MCG manual is your best friend for all things coding.
Always.
Keep practicing with real-world scenarios and don't be afraid to ask questions.
The more you practice, the more confident you become.
Exactly. And that confidence will shine through on your exam.
You know what? You're right. This deep dive has not only given me knowledge, but also a boost of confidence.
That's what I like to hear.
So, for our listeners out there, remember, every code tells a story.
It does.
Take the time to understand those stories, the anatomy, the procedures, the nuances.
And you'll be well on your way to coding success.
Absolutely. Thanks for joining us on this incredible deep dive into nervous system surgery coding.
It's been a pleasure.
Until next time, keep those brains stimulated and those coding skills sharp.